Sorry. 1 second. I thought I had it there. So, friends, one thing that I would request you to look at. I have given the link here for the introduction to the Lancet Commission on the Value of Death of 2023. It's a long document, but at least see the executive summary and key messages and recommendations. I think that will be valuable for you. Sangeet, I'll request you to forward the presentation to everybody.
Sure, sir.
And now a difficult question to you. Many of you are young people. Not fair. But do please answer this poll. Sangeet, can we
Yes.
have the poll on? You click on the right answer.
You can choose 3 options.
So, to the people who are unable to think about it, your own death, I know it is not easy. But to them and to the people who are not sure, I still want to say one thing. It's a great strength to be able to think about your own death for more than one reason. First, death is the inevitable consequence of life. It happens to everyone. And being able to think about it, about your own death, for one thing, adds meaning to your life. Now you will decide what's most important. Okay, I will die someday. These things are the most important for me. That line of thought is possible. So you are able to concentrate your life on the important things. And secondly, this affects you several times in your life. The death of a loved one. You want to be able to handle that also. You don't want to be so desperate at that time that you don't know what to do and you say meaningless things which causes more suffering to your loved ones. So, congratulations to those who are able to think about it. And to the others, I'm not talking about next week. I'm talking about now. Please try to think about it so that you are able to add value to your life and have a meaningful life so that you can help others who are facing death so that when you think about it, you know them. And of course, when the time comes, let us hope that is 80 years away, to die as well as possible. Here is one more poll for you. Do you think your duty to sustain life, your duty as a doctor to sustain life, does it mean that you have to have everyone who is going on a ventilator, even if the person is having advanced cancer? Sangeet, poll please. Sangeet, if the poll is not ready, that's also okay. We can manage.
It's just launching. I think there's some network issue.
People are answering in the chat box already, sir.
Oh, good.
Because nearly 50% are saying no, and the rest are answering not sure. Mostly
So,
no. Most have gone for B.
Okay. It is a sad fact that in our country, this happens. Let me tell you, you do not have a duty to keep the heart beating indefinitely. Very much otherwise. Unfortunately, this is misunderstood in our country, like the people who said not sure. And the majority of younger medical graduates, those who graduated in the last 25 years particularly, believe that they have a duty to prolong the life. Unfortunately, that causes a lot of suffering. Dr. Sankha Mitra is a British oncologist of Bengali origin who does charity work in the northeast of India. And he is appalled by the state in India, where the poor die in misery, middle class die in misery, and the rich die the worst kind of deaths on ventilators. I hope I will not have to go through it. And please understand that this is not universal. It doesn't happen in high-income countries where they can afford it. See, this publication is from 2016, shows that 90% of people in the ICU, when the treatment is considered futile, are taken out of life support systems and given palliative care. See? Whereas, see what happens in India? Only 30% have that privilege. They don't get palliative care. They are just taken off ventilator and sent home. A very unethical thing to do. The Dr. Raj K. Mani, the famous intensivist from Delhi, talks about this practice of Lama and Dama, leaving against medical advice or discharge against medical advice. But the other 70% are continued on life support systems till they die. This is an Indian disease. It is not a global disease. Whereas when my time comes, I am very clear. I was an intensivist. I know that intensive care can save lives when life is salvageable. But if not, when my time comes to leave this world, what would be important for me would be these things. Do you know of any intensive care unit anywhere who will allow a child to come in and give the dying person a kiss on the cheek? So let's be clear, friends, that you do not have a duty to prolong the heartbeat at all costs, ethically or legally. Your duty to me, when I am your patient, is to make me as comfortable and as much in peace as possible. I have deliberately put in physically first. If I am in agonizing pain and if I cannot breathe, my mind is full with that. There is no way you can give me psychosocial support at that time. So make the person comfortable, as symptom-free as possible, and as comfortable emotionally, socially, and spiritually as possible. So earlier I asked whether you have a duty to prolong the heartbeat. This is how the healthcare provider's duty of care is officially defined in India by the bioethics unit of ICMR. Your duty, friends, when I am in that bed, when I am in the last stages of my life, your duty is to relieve my suffering. See the last line? There exists no exception to this rule. Cure when you can. Relieve the symptoms whenever you can. But always be comforting, which is precisely the opposite of what will be achieved in a death in an ICU. But how do you know that the person is deteriorating and nearing the final stages of life? I will not describe it, friends. As I said, you will have this presentation. This and the succeeding slide, 2 slides, I would recommend that you print it out and keep it somewhere where you see patients. A patient who is totally bedbound, no activity. I am coming to the second bill from the bottom line. Receiving, needing total care, maybe taking only minimal, no fluids or only minimal sips. Will be, sorry, I have to go back. So that person who is drowsy or whether conscious or confused has a palliative performance scale of 20%. The person is no longer conscious with everything else, then it becomes 10% performance scale. So depending on this, there is a way of assessing the prognosis. You will have this all the time. The children from Dubai or New York coming and saying, how long is it going to be? I need to make arrangements for my children's school, for my job. With cancer, a person with 10% score has only about 2 days of life left. But this is only 80% sure, statistically. Whereas if it is a non-cancer patient, usually it is much longer. So this will help you to do some prediction. And so to that son or daughter, I'll say 80% chance is something like this. But there is always the other 20%. As I said, I'm not going to describe this. We do not have the time. But Sangeet will send it to you, and I hope you will look at it. And if you have doubts, I hope you will come back to us. Now, you have some protocols. If somebody is bedbound, you keep changing position every 2 hours, right? But maybe you need to make some allowances when I am on the last phase. Okay, I don't want a pressure sore even on the last few days. I know. But if I have not been sleeping till 2 a.m. and finally I drop off to sleep, please don't wake me up at exactly at 4 o'clock. Be a bit flexible. I need some consideration. These are my final hours or days. And if I am unable to drink, hey friends, you can't continue to have a full meal or even a drink in your last few hours. It's okay. What happens to the body is that the body is no longer functioning properly, does not need food. A loving child will be very worried. Your mom is not eating anything. How will she live? Well, towards end of life, metabolism drops, need for food drops, need for water drops. The daily water intake may be only about 500 or at the most 1000 ml in a warm environment. And even for the last 1 or 2 days, you can leave it be. If the lips are dry, just moisten. But if fluids are necessary for me on that day, Dr. Jyoti, Dr. Reba, Dr. Raman, please do not keep poking for my veins. Radha, I hope one of these days they are taught or they will be taught how to give subcutaneous fluids for these patients. This is absolutely essential. And I'm not suggesting something that is unscientific. You will find a detailed description in the Oxford textbook of palliative medicine. And many medicines can be given rectally, including morphine, except possibly for some antibiotics. Most medicines can be given rectally. So that would be the compromise, subcutaneous and rectal medicines, rather than a nasogastric tube, rather than an intravenous line. And will you continue to do all the investigations? Parthasarathi Shom was a formal financial advisor to PM, the Prime Minister Manmohan Singh. And he wrote this in the Business Standard in 2016. He said when his mother was dying, they went on poking her to collect blood samples. And on the final day of her death, they were still drawing a blood sample for a liver function test. And he asked, how would it help? The doctor said, we have to keep trying. No, it is assault and battery on the person. Don't do it. We have to reconsider what investigations are necessary. There is a time when even the sodium level should not be checked. I would rather not have you have a pulse oximeter on me, because once it's on, you will start treating it, not me. Stop all unnecessary investigation. That calls, oh my God, statins in the last week of life, multivitamin tablets. So all these you will have to learn to not to do. Just because you have them, just because you have a hammer, everything should not be considered a nail. My comfort is what matters now, not my saturation or serum sodium. Sometimes, usually not, but sometimes antibiotics may be needed. Like a respiratory infection may be causing so much a cough, distressing, but only if necessary. If the patient wants to be at home, allow him to be, provided you can give him some kind of care. And well, let me re-emphasize about feeding tubes. During the discussion, you can bring up questions. Many people accept everything else, but this is troublesome. But it's not only about the physical things, it's also about the psychosocial spiritual support. There are a few things that you have to look for. One, what connects me most to this world? What is the factor that connects me most to this world? We'll talk a little more about. But most importantly, listen to me. Maybe I have only a month to live. I may not be able to share all my concerns with my family. I don't want them worried. But I want to ask them to someone. If you can, sit down with me. Sit, not stand and look down upon me. And let me tell you what are my biggest concerns. And if I'm having a great grief, regrets or I wish I hadn't done that, or guilt about having done something. Listen without judging me. You are not a judge. You do not have that responsibility. Non-judgmental listening. And in my story, if I say about some achievement that I have had, pick up on that. Acknowledge it. I feel enormous respect that you could do that, something like that. And finally, sometimes as I keep talking, I may become quiet. What will you do? Just be quiet. I need that break. I am thinking hard. Who wants to read this out for me about Pooh and the piglet? Volunteer. I am tired of listening to my own voice. So boring. Who do I see? Shanmuga Priya, would you mind unmute and reading?
Today was a difficult day, said Pooh. There was a task. Do you want to talk about it? Asked Piglet. No, said Pooh after a bit. No, I don't think I do. That's okay, said Piglet. And he came and sat beside his friend. What are you doing? Asked Pooh. Nothing really, said Piglet. Only I know what difficult days are like. I quite often don't feel like talking about it on my difficult days either. But goodness, continued Piglet, difficult days are so much easier when you know you have got someone there for you. And I'll always be there for you too.
Within our limitations, thank you, Shanmuga. Within our constraints, it's very important to be there for the person. And sometimes just being there is vitally important. I'm saying that you, the doctor, may not have the time, but someone can. Maybe sometimes a nurse can, maybe sometimes a social worker can, or a volunteer can. But you will need to remember this because you are not going to look after only your patients in the hospital. Someday you will have to look after your loved ones. Please remember, time with them, respectful time with them, non-judgmental time with them, silence with them. Companionship can be very valuable. Tell me, what connects you most to these worlds? Here's a poll for you. Please answer this. Sangeet?
Yes, regret to inform that there is a technical issue with the
Okay,
code.
okay, don't bother. Hey, you can answer to yourself. I'll be quiet for 30 seconds so that you can think, reflect, and decide. Radha, is anybody responding on the chat box?
Yes, yes, plenty of responses are there. I'll just read it for you.
Okay.
Many are telling family.
Mm.
Only one person has said God, faith.
Mm.
And like mostly family.
Okay.
And one person has said family and occupation, and it is Dr. Jyoti.
Yes, yes. Dr. Jyoti, many people are so involved with your job that you may find it difficult to have any life apart from that. That can be a bit of a problem. So I know that people, when they are no longer able to work, find it very hard. So when you have a patient like that, it is generally very good strategy to sit down with them and talk about it and help them to find something else in life that interests them. I think that's vitally important.
God, faith, and family also, that combination some people have said.
So for the person whose faith is vitally important, it may be God, it may be religion, it may be the rituals. We have the job of making that possible. Sometimes hospitals, I have had the experience of a hospital trying to prevent a last communion, which is vitally important. Your Bhagavad Gita or Quran or Bible being read may be important for you. And generally, an ICU will prevent that. Another reason why that's not a good place to go. good place to live in your last few days. Let me come back to the presentation. So this is again, you want your family with you at that time, your home. Please remember that an intensive care unit prevents most of this. And therefore, it's good to know, you ask, try it with your own family, your grandparents, your uncles or aunts. You don't have to wait till they are dying. Just find out, have conversation, sit down with them. Amma, Maji, what is most important for you? There is this question that we came across in the classroom. What do you feel connected to most in this world? And when they tell what it is, your life gets enriched. And once you have this data, these details, when you are going ahead with the treatment of your loved one, you will be able to find unfinished business. Oh my God, I have made that will, but I have not registered it. Can I get it done? Oh, I have not made a will. Oh, wait a minute. I know that you want to give this chemotherapy, but give me a day to go through this. And depending on the person's choice, enabling religious practices without forcing it. Sometimes, many of us quarrel within the family, property dispute, something unkind spoken. Two brothers have not spoken for 3 years. The most important thing, after you have treated their physical suffering, would be to try to rebuild it. Just sit quietly. I'm sorry that you had that quarrel. Can one of us call your brother, talk to him? That kind of thing can be very valuable for peace of mind. And whenever the family can ensure their presence, and remember children, if possible. And suppose this is a destitute patient. It happens to us not infrequently. Nobody except the manager of the poor home who will be too busy to come over. There you become the connection. Those people need extra care. You, the busy doctor, may not be, but somebody in the team has to be there as a new relative of the person. And those who have read about Dame Cicely Saunders and St. Christopher's Hospice would have read about the story of a Polish gentleman, migrant, with no relatives in the UK, dying and giving her 500 pounds that he had saved in his life and saying, I want to be a window in your home. Legacy. Leaving something behind in this world for the right person can be very, very valuable. Please listen to my story without judging me. I'll repeat this. I might have never told this to anyone because my family, I may not say this because I think they'll be worried, but I can talk to you. Validate my feelings without finding fault in me. I repeat that. Acknowledge my achievements. And as the piglet and did to the poo, respect silences. Be there as a companion. Sorry. And particularly, remember children as caregivers. And remember children as patients. I wish I had some more time to tell you stories. You all know about Elizabeth Kubler-Ross? Elizabeth Kubler-Ross, who was called the death and dying lady, who did more. Radha, can you please write her name on the chat box so that everybody can see, and at least Google for in Wikipedia for Elizabeth
Yes,
Kubler-Ross.
I will do it.
Thanks. Kubler-Ross describes this story of overcoming considerable resistance from the patient, disclosing incurability and impending death to an 8-year-old child. The child thought for some time and said, Dr. Rose, I want you to come with me. I want you to take me home with my parents. She was taken aback, but she went nevertheless. When he went to home, he asked his father. There was a new bicycle that he had bought for him. He had never ridden it because he was unwell. He asked that the bicycle be, it was shackled to the wall to be brought down. He wanted to mount it. The father was very scared. Kubler-Ross encouraged him. The boy did 2 rounds in his bicycle around the yard, came back and handed the bicycle over to his younger brother and said, you can have it. He was finishing his unfinished business and leaving a legacy for the younger brother. Children harbor great worries, whether they are patients or caregivers, they need special attention. Hey, another volunteer to read this article by Sindhu, a non-medical person in the Hindu in 2016. Who is volunteering? Yes, please. Thank you.
Yes. Sindhu S. in the Hindu 9/8/2016. My 84-year-old father, my best friend, was enduring raw, intrusive medical procedures against his own wish. All skin and bones, he looked defenseless and at the mercy of doctors, his arms tied up, vulnerable, and agonized. Thank you, sir.
Thank you, Dr. Yash. This is assault and battery. There is no justification for this practice, and I hope each one of you will be an activist advocating against this. This recommendation is from the National Cancer Grid, a collaborative of more than 300 cancer hospitals in the country. Wherever you are working, it's very likely that your institution, if you are working in a cancer hospital, your institution must be a member. And together, they have created these 10 low value or harmful practices to be avoided. And one of them is, do not treat patients with advanced metastatic cancer in the ICU unless there is an acutely reversible event. Between principle and practice, often there's a gap. It's up to you, every one of you, and me, and all of us, to be advocates against this injustice. And please remember, withdrawing of a ventilator, withdrawing of a life support system, taking out an nasogastric tube which is worrying the patient is not euthanasia. This also comes from the bioethics unit of ICMR. This is applicable for the country because it's a statutory body of Government of India. Withdrawal of artificial life support is not euthanasia, though in the recent Supreme Court order, the court erroneously called it passive euthanasia. Withdrawal of artificial life support is allowing natural death. We do not have the intention to kill. We have the intention to allow natural death. And passive euthanasia is not an accepted term. So, please be clear. Withdrawal of artificial life support in the context of futility is not euthanasia. So, the way to avoid this, I'm particularly talking to the people who said they are able to think about your own death. You don't have to wait till you are my age. You don't have to wait till you are ill. It's good to be protected. You never know what will happen, what awaits us. Prepare a living will or advanced medical directive. A recent Supreme Court judgment of 2023 lays out the process. I have signed a doc. I have actually done that. Express my wishes. I've named a relative as my surrogate. If I am unable to take a decision, I have talked to this person. I have talked to with my wife, my 2 children. But if they are not there, I also talked to a nephew who can be my surrogate. I put these names in. And when I have written this, you, the doctor, have the duty, ethical and legal, to respect my wishes. You shouldn't to intubate my trachea against my wish in that context. There are a few bureaucratic steps involved, which is a concern. So, as I said, advance directives written by me are valid, and withholding and withdrawing of life support is necessary, the court says, in the context of futility. So withholding is easy. You just say, okay, I hope my wife or my children will tell the doctors, no doctor, no ventilator, no artificial life support. But if I am already on a life support system, then it is harder. Legally, they have put in this procedure. There has to be a board of 3 doctors. It can be done immediately. My treating doctor and 2 more specialists can come together and declare that I am unlikely to come back to reasonable quality of life. But then the hospital has to inform a DMO and have another board, external board, who also will have to certify this. And then you can allow me to go. So I think I have given the link here to our website web page to go to Pallium India website. You download the form, customize it to your own wishes, express your wishes. All that is necessary to get it countersigned by a gazetted officer. Keep a copy with the medical records. They also ask for a copy to be given to the judicial first class magistrate, but they have no system of keeping them. But most important thing, this thing is of no value at all if you do not get the concurrence of my family. Because any sensible doctor will know that once I am dead, I will not go to court. Okay, I have the right. Who is going to exercise that right? But a living family member may go to court. So any sensible doctor, whatever I have written, will not act against the wish of the family. Common sense. So it's very important to talk to the family of this matter. So before I conclude, I will mention these usual barriers. This is not from any particular document. This is from my own perception. I believe, yes, we doctors very often say, but the family is insisting on that. Oh, the law is not with us, etc. But I honestly believe the biggest barrier is the doctor's perception of duty of care. Family's attitude is a problem. You cannot do it at one sitting. Repeated conversations will be necessary. And you may not always win. The societal attitude will be a problem. All the family members, hey, why are you not taking him to this hospital, the most expensive hospital? And hey, he's your own dad, right? You don't want to spend money on them? All these cruel questions will be there. So I generally talk to the family and tell them, anticipate this. This always happens. Everybody will have a different solution and they'll want you to do this. Don't quarrel with them. Just smile and be silent and do what you think is best for your husband, your wife, your child, your parent. You won't do any harm to them to please a family member. Finally, I wish there was a law governing this in our country, but the 2023 Supreme Court order gives a reason for some hope. What we need to do, I mentioned the Lancet Commission report. What they recommend is, you need palliative care literacy, including death literacy. The public needs to know what's happening in the last quarter of a century, the injustice to the dying person. And all of us, I hope, will be advocates. All of you, I hope, will be advocates for me when my time comes to let me go with some comfort and dignity. I'll stop there and leave it to Radha to conduct the discussion.
Thank you very much, sir, because this is one of the issues and things everyone has been asking. So what happens at the end? Because they have had sessions on ethics and everything. Now putting everything together, and you've taken them through very well. First, I think I will ask if someone wants to unmute and speak and ask something to you straight away. We'll do that first. Anybody wants to ask? Because I think only one person for the question of yours asking whether such a patient needs to be ventilated, I think one person answered yes. I think it was Dr. Sri Sudha. Is that right? Are you changing your mind now, or are you still telling that cancer patient who was nearly in that prognostication thing, like 20%, would you still like to ventilate him? Do you think that's your duty of care? I don't think I'm, just because I saw that response, which was the only response like that. So do you want to unmute and speak, Dr. Sri Sudha? Do you still have that feeling, or have you changed your mind? Okay, if she's not unmuting and speaking, anybody else wants to ask or have any?
Radha, Dr. Sri Sudha may not be ready to speak about it.
Correct.
But people have so much of conflicts within them. But how can I? It is unethical not to feed the person. These questions will be there. So anybody, if you have questions like that, please bring up. And Dr. Soumya, Sister Soumya, Reverend Sister Soumya, I saw your name. I hope I am not mistaken with your name. And particularly in relation to God, faith, or religion, you may have comments or questions.
Sir, shall I say something? I mean, Tokyo speaking, sir. Good evening.
Yes, please go ahead.
So being a doctor and an anesthesiologist, many a times, be it end stage of any patient or subjecting the patient for any life-threatening surgeries or taking away the life support, the onus of responsibility will be thrust upon the doctor. Everybody will say, whatever you say, we will do. So like that, the doctor will may, I will not, many times I found that I was not in a position to take a decision for somebody because they can't solve, they give so much of trust. Under such a situations, what should be the attitude of the doctors?
Thank you for the question. Radha, I couldn't see the person. What's the name?
Dr. Kotur. I was also initially not able to see. Now,
Dr. Kotur. Hello.
Dr. Kotur.
Both of you are there. Okay. Husband-wife team participants.
Yes, sir.
Dr.
Yes,
Yes, sir.
Pushpa, good to see you too. Dr. Kotur, thank you for asking the question. It's a question that's very relevant in ethics. In ethics, we all talk about autonomy. That means if I am the patient, I have more right to take the decisions than you. Whatever degrees you have. This is my body, I will take the decision. Please remember, everybody, autonomy is a right, but not a responsibility. I can't make up my mind. Dr. Kotur, I trust you. You have looked after me for 23 years. I'm handing my life over to you. Please advise me. And then, very often modern doctors say, no, I can't do that. It's your right, it's your life. You will have to take a decision. I think that's cruel exercise of the autonomy. So what is necessary is a weak paternalism. Paternalism, you know what that is. The child doesn't want to school, you carry the child to school. You are going to school. And you don't leave it to the autonomy of the child. But what I'm recommending is a weak paternalism, meaning you need to put yourself in the patient's place. You need to have enough empathy. You need to have the empathy to put yourself in the patient's shoes and think from his or her kind of place. And then you may say, then you are also hurting. This is about me. If I were in his position. And then you may say, look, I know you, but I do not know enough about your feelings. But I think if I were in your place, I would take this route. This exercising a weak paternalism, thinking for the patient, and not taking a decision for him or her, but saying, if I were in your position, this is what I would do. Dr. Kotur, are you happy with that?
Yeah, weak paternity, yeah.
Yes, thank you.
Yeah, if we can say if he was to be my father, I would have done this, or if
Yes.
that kind of a weak paternity.
Yes, Dr. Yash Javeri. Yes, I thank you for highlighting that. Autonomy is a right, not my responsibility. I trust you. I hand my life to you. Please decide the best for me. Thank you.
Sorry to interfere. What we generally tell the patients, still I was also doing the same, that this is a medical decision, social decision. You have to take medical decision. We will take, but we should help them arrive at a decision, and we should be giving them the right information and pathway for the decision.
Yes, Dr. Dayash. And all that I'm adding is if they are unable to take that decision, seeking your help, then you exercise weak paternalism. Jatha, I have left you a message on the chat
Yes,
box.
we will go ahead with the
about
case and then we will continue with the discussion, sir.
Jatha,
Vivek, thank you.
Jatha,
Yes, sir.
I have left you a comment on the chat box
Yes.
as a personal message to you. And doctors, please bear with me. A friend and relative has lost his mother, and I have to go and see him now. So please allow me to leave now. Sangeet? Okay, Yadha, thank you.
Thank
All
you,
of
sir.
you,
I have
thank
seen
you.
the message and I will convey it in the case discussion.
Okay.
Thank you. Thank you,
Thank you,
Vivek. Thank you to you.
Thank you. Ma'am, can we move on to the case presentation?
Just a minute. We will go ahead with the case discussion. Sangeet, will you share, will I be able to share screen also? Because I just want to add on one more thing after the case discussion or something like that, so that we'll do it afterwards. That time, if you could give me, if I could share my screen
Yes,
also.
ma'am, you can share, ma'am.
Okay, then, see, this is one important topic where many of you would have had queries. And again, Dr. Sri Sudha, I didn't want to point you or anything, put you in a fix or something like that. Okay, I just thought, even if you see, this is the platform where none of you should feel hesitant, because where on earth you will get 80 people interested in palliative care and a pioneer in palliative care able to answer your queries. So that is the only reason I keep telling every time, because finding someone interested in palliative care, willing to go about with it and talk openly is a rare commodity. Okay, that is the only thing. And don't feel anything like that. And it's a doubt or query which many can have, because that is the like indecisive state. Okay, and what Dr. Yash mentioned is what I was also about to say, that as Dr. Rajagopal said, thanks to God, I have also been an intensivist for 25 years, working in 3 continents. Okay, so in that front, I would say, when I speak to family, yes, and not one in intensive care, I would have spoken to the same family few times, and I will say it is entirely a medical decision. Don't think that you are making the final decision and telling, oh, is that what I have done? Have I made the decision? And have I caused some problem? No, not at all. In 25 years of working in intensive care in these type of patients, this is what generally we have seen. So it is not you making the call when we are explaining about withdrawal or withholding treatment. That is what will be done, and this prognostication and things are done through the admission, through every time. And in fact, we do it 24 hours, 48 hours, 72 hours, A to Z of all system, cardiovascular, respiratory, what or how, like for example, you have a 3-day time we're going to see from day 1 to day 3, we'll see the progress or the progression. If in the 3 days everything has gone downhill, we have got 4 organ failure, then what is going to happen? So that is important. And as Dr. Yash has a message of, that guilt feeling of the family is not, because the surviving family is what is going to face everything. So all that is also part of our duty. Okay, so that is the important thing. We'll go ahead with the case discussion. Anything anybody wants to ask, please ask. Otherwise, we'll go with the case discussion and come back. Yes, Sangeet, we can go ahead with the case discussion.
Okay. So case presenter is Dr. Devashish Bhattacharya. So over to you, sir.
Hello everyone, I am Dr. Devashish Bhattacharya. I am BDS. I have completed my degree last year. I got to work in a palliative setup for 10 days. During that time, I encountered a patient. It is about her only. Change the slide. Age 50 years, gender female, carcinoma right lung, bony mets. Presenting complaint. The patient was presented to our hospital in stretcher with complaint of severe pain in right chest region. Visual analog scale, it was 10 out of 10, and the pain was continuous and dull in nature, and it radiated to entire upper body. The patient had severe difficulty in breathing and was almost gasping. She had a complaint of nausea and recurrent vomiting. The patient was unable to lie down in supine position. The patient also complained of cough and expectorated blood with sputum. The patient had difficulty in swallowing food and was only able to consume liquid diet only. History of present illness. Patient had a history of pain in right chest region since last 6 months. She had a history of severe cough and increased sputum output. She had a history of difficulty while lying down in supine position. She had a history of smoking tobacco, mainly bidis, history of hemoptysis. She also had a history of reduced appetite, weight loss, and mild difficulty in swallowing food. General examination revealed absent breath sounds. She had fever 103.4 degrees. Pulse rate was abnormally high, 102 per minute. Oxygen saturation in normal air was found to be 86%. Blood pressure was low, 80/60 mmHg. She also had tachypnea. Respiratory rate was found to be 42 beats per minute. She was cachexia, asthenia, facial edema and plethora, dilated neck veins, and she also displayed signs of pallor. So after we received the patient, we sent the patient for basic investigations. PET CT scan, whole body revealed. FDG, avid soft tissue mass noted involving right lung lower lobe, multiple pleural-based solid nodules and pleural deposits noted involving right lung with right-sided pleural effusion. FDG, avid sclerotic region noted involving head of humerus. Treatment. After confirmation of the diagnosis, we referred the patient to the oncology department for primary disease management. But the patient was found to be medically unfit for chemotherapy or radiation therapy due to the advanced progressive nature of the disease and irreversibly deteriorated health condition of the patient. Hence, palliative intent of treatment was the plan, and providing best supportive care to the patient was the goal to improve her quality of life. So here our main concern is to initiate end of life care as the disease has already progressed to a point where it cannot be reversed. The patient was restless due to severe pain, had severe breathing difficulty, and her vitals were unstable. She was responsive to verbal command but had incoherent talks. Hence, in this scenario, our main concern was to relieve her sufferings and give her a dignified life till death. Hence, we started the patient giving oxygen support through mask at the rate of 4-5 liters per minute. Nebulization was done with Duolin and Budacort. Bronchodilators were added. Dexamethasone was given. Intravenous morphine was also given to the patient as she was unable to swallow solid that tablet morphine to relieve her pain and respiratory distress. Despite all this, her restlessness was not relieved, and we had to give sedatives like midazolam. In this case, our main goal was not to hasten or delay the death, but to provide a pain-free, dignified, natural death to the patient. Psychological aspect. Okay. So, in this case, it is necessary to explain the patient's near and dear ones regarding the poor prognosis of the patient in the vernacular language of their understanding. We should be empathic to the patient's family. In this case, she was a mother of 2 young children. Giving realistic hope is another important aspect. Sometimes silent listening to their grief rather than prompt reaction can be useful. Involving social workers if the patient party is in financial distress to provide any financial aid through government schemes. So let me summarize it. A 50 years old female patient is a known case of metastatic lung carcinoma who presented to our department with severe pain, restlessness, incoherent talks, and difficulty breathing. Our main goal was to provide best supportive care to improve her quality of life. So the discussion points based on the patient stories, the goal of palliative care should be explained to the patient party. There is a need of palliative care for all patients suffering from life-limiting illness. Pain-free life is everyone's right. In this case, it is necessary to explain the poor prognosis of the patient. Another important aspect of palliative care is to reduce the financial burden of the patient party and adherence to medical ethics. Thank you. I'm done.
Thank you, sir, for the wonderful case presentation.
Thank you very much, Doctor.
Thank
You have
thank
brought up such an appropriate case. Sangeet, maybe we could come out of this screen because the main discussion points, I will just read that out once again, Sangeet, just the last slide.
Okay, just a minute.
Just go to the last slide. Thank you. See, the main discussion, these are the 5 points which we will discuss. What the goal of palliative care, explaining that to the patient and family. Then, what is there a need? What is the need? Then, pain-free. That is the most important goal. And then, see, the fourth point is inside the first point itself. What is that? Is if you tell that when you're telling about the disease, prognosis also, and then financial burden. We have no right to cause financial burden and debt to the family. That is also medical ethics. Okay, that is justice. What is the fourth pillar of medical ethics? Okay, thank you, Sangeet. So that if we come out of the screen, that might help us to have everyone in view and take it from there. Okay, thank you again, Dr. Bhattacharya, for bringing such an important and appropriate case. This is what we say always. We'll have this open discussion. What all needs to be told, like point by point, if we say, what is that you have to explain to the patient, to this patient and family. Having a young family, what is that is important, and what is that you have to say. We come across these cases very common. Like I have seen like 40-year-old women with 2 children, not even 40-year-old with a young. She was a similar case, IT professional, and her children were like 11 and 6 or something like that. So these are becoming very common. What are all things that you have to tell? Anyone can see. This is an open discussion. As I say, only if you come up now, then we'll make things easier for all of you when you really face patients. Dr. Bhattacharya, yourself, whatever you did with the patient, do you want to go ahead and say? You're muted.
I do not have much experience in oncology setup, ma'am. It was just a 10 days experience. Finally, the patient died, but what I feel, our medical team was able to give the patient a dignified death. We avoided.
Okay. So go ahead. Whatever you want to say, tell, and then I will.
The most difficult part, what I feel in this case, was to explain the patient's children about our intent in palliative care. Even at the end stage, they were expecting the patient to recover, their mother to recover to back to normal life. They wanted blood investigations to be done. They wanted the patient to be sent again for chemo, radiation. They wanted primary disease management. But explaining that part was the hardest part.
See, that is what. Okay, thank you. I will. The main thing is that it is the important duty of the treating team. See, when at that stage of her situation, it is a bit too difficult. So that is why we say this palliative care options and things, goals of care have to be done from the time you start seeing the patient. And in his presentation, he very clearly said that with the investigation, they found that the disease was progressive, advanced, and she was like, we have assessment, to find out whether they are fit for having treatment. In his slide, he was very clear. It was mentioned that she was found unfit for the treatment. Her disease progression might have been bad, and her general condition might have been in such a state that she was not in a situation to cope with the treatment options. Okay, these all have to be explained by the parent oncology team, not by the person who is seeing her in the last stage where she's coming gasping for breath. So that is where the difficulty comes. Okay, so explanation, it may not happen in one day. When it is a young mother and things, they will want to try all options and see if A doesn't work, B. Many times what happens, they will say, no, all your treatment, we will go for naturotherapy. Yes, we have seen all this through our practices. We don't say no to any of that, but we have to explain to them, these are the situations. This is where prognostication will help. Okay, and there are very clear figures, especially if it is oncology. The prognostication number and validation are very high. If it is non-oncology itself, we have Dr. Rajagopal. Anyhow, you will be getting the whole presentation. Those two slides which you saw are very, 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 very important. Okay. The scaling of palliative care status, which was a no. So this lady, see, she's gasping for breath, unable to do anything for herself. So she will be in the 10 or 20%. Only 10% I would put her in. Do you want to say something, Dr. Bhattacharya?
We can say she was in almost 10% palliative performance scale.
Exactly. That's all. So that palliative care scale is something important. And then based with that figures, you go on to the prognostication scale. Okay. So here, two important things. You have to foresee. You have to foresee how her condition is progressing and foretell. Okay. Foresee her condition with all clear figures and facts. And then foretell those facts truly to the family. Okay. And give realistic hope, not give false reassurance. See, every word that I'm telling is important. And this is what has to be told. Okay. So this much of explanation and things have to be done. Okay. And then next important thing, what I'm going to say, don't tell them that, oh, nothing can be done. Here, when cure is not possible, care is always possible. That is what Dr. Yash had typed in the chat box. Okay. So many times cure is not always possible, whereas care is always possible. So you have to tell them when cure, that is where will be helpful to the family and things. And here, when you have children especially, it is best to get the help of a psychologist. Okay. Generally itself, when some young patient you have, it is difficult. We see a lot of 20-year-old patients, we see a lot now. So, for example, I've seen few people who are fourth year engineering or just finished engineering coming with a big osteosarcoma. This is a lot of patients in the last 6-7 years I have seen. Okay. So, but in those situations, it is best. See, these patients are not getting to that stage overnight. Okay. 1 year, 2 years also it goes on. So you're losing the golden hours many times, but that is not the way forward. Okay. That is why we are telling, start utilizing the palliative care option early. That is why it could be many times the parent team or the oncology team, they are telling overburdened. Everyone is overburdened. But to identify and direct, it doesn't take hours, minutes, seconds. So everyone has to know their responsibility. Okay. So getting hold of, if you can, a psychologist will be very helpful when you have children. Okay. So that also has to be taken care of. And that is where you say that whatever cure cannot be given, care can be given, and how. There you say how the disease and the situation can move forward from now on till death. You have to explain. See, exactly, you may not be able to tell date, time, and no one can say. When they ask questions like how many, see, these things is not in anybody's hands. Okay. That is why we say months, years, days. That is how we say. No one tells date and time. No one on earth can give. And that is not wrong if you're unable to say, because that is how it is said. Okay. So that one. And then third point, pain relief is the most important thing. Okay. She is in agony there. Okay. So if there, and you've all heard about morphine trial, no, you can use the morphine trial. You're not overdosing. You're giving, do you all remember the morphine trial? Do you want me to tell it again? Or someone can tell? Dr. Kavita, you can just tell that in simple words, or if anybody else wants to say also can say about the morphine trial, how you could give so that you can help the patient.
can give by IV. We can, in this patient, we can start by giving it IV and titrating it according to her, whether her pain is relieved or not, or otherwise, if there are any signs of respiratory depression when it comes up.
Exactly.
Like, yeah,
That's what.
so 1.
You dilute
yeah,
it, dilute it
1.5
according
milligram.
to the according to your available. Like if your ampule has 10 milligrams in 1 ml, you dilute it to 10, like 1 ml with
10.
9 ml.
1 ml.
Or if it is 15 milligram also, you dilute it 1 ml to 10 ml. But if it is 15 milligram ampule, each ml will contain 1.5. If it's a 10 milligram ampule, each ml will contain 1. See,
1
these things are important for us, and give each time you give 1 ml dose, 1 ml, which could be 1 milligram or 1.5, and then wait for 10 minutes, see signs, then document everything, and then get to the state you can achieve very good pain relief. This is one thing in this condition. Okay, and once you get pain relief, that is the best thing what the patient would that is the best for in patient's best interest. Okay, so pain relief, and then think of per rectal. So in these type of situations, paracetamol, diclofenac, everything can be given per rectal. You have all those suppositories available nowadays. 1 gram paracetamol, 100 milligrams diclofenac, 50 milligrams, everything is there. Okay, and giving per rectal is such an easy thing, and it does give a great amount of pain relief. Okay, so pain relief, providing pain relief is very, very important. Okay, and then prognostication, what was the fourth point, has come in the first point. It's a 5 explain. It is our duty, as I said, once again, I'll tell, foresee, predict, foretell. And tell realistic assurance, no false reassurances. Okay, because at that stage you have to, and again, you don't tell everything in one go. In these type of patients, when you have every 2 hours, is another statement I'm going to say. All of you whoever is working in ICU will be knowing, in ICU, nothing like everything changes in minutes and seconds. It is not like morning I told and afternoon, evening. No. That is why we have arterial trace and things like that, which gives us beat by beat variations. Okay, so we have to tell also to the patient and family, that changes will happen every minute. Any change in patient condition, I will inform. Unfortunately, many things don't happen like this in intensive care. I am very, very sorry to say. Even doctors are not explaining, and I have been a family and I have struggled to get doctors to speak in India, which is a very unfortunate condition for many families. Okay, so those things, prognostication is important, and that you do, and you explain things to them. That is how it is, because if you're an intensivist, that is also your duty. Okay, and then fourth point, last point, financial burden. That is, again, it is unethical to do all what's happening. So there, as Dr. MR mentioned, let us all make a decision that we will all play our part to see how much can be done to avoid these type of things. Okay, and if such financial burden comes, it is the surviving family who is going to go through with it. I will just give an example. Okay, you have for example, you have a patient with a 20-year-old or a 19-year-old studying in university, paying fees, and for that fees you have to pay 2 lakhs, and here you're going to spend 2 lakhs for a futile, which will not, irreversible. See, again and again, correctable causes, we as intensivists, all of us will do something if it is correctable. If it is not correctable, irreversible, they're going on and spending time and money is what we are all trying to be sensible and logical, not that irrational. All that you cannot do. Okay, so if you do that, so at least that child who needs to go to university and pay and study and pursue with that life and look after the mother, maybe. So start thinking. So that is why that total what we say. Physical, social, psychological, spiritual. Put everything in. See, even as doctors, what do we say? Don't treat numbers, treat the patient as a whole. Look into all systems, A, B, C, D. That is how you go ahead. Okay, airway, breathing, circulation, that is the same pattern you keep on following. Okay, those are the important things to be kept in mind. And anything more anybody wants to add on with the discussion? Please do. Dr. Devesh, have I gone through all your points of concern? Are you first convinced and satisfied the way I took you through?
Yes, ma'am. I'm done, ma'am. Thank you, ma'am.
Okay, anybody else who wants to add on, to what I've said, please feel free and go ahead.
Adam, in patients with cancer, oncology
Hmm.
patients, it is okay, easy to prognosticate. But however, in other systemic diseases like in respiratory and all, it becomes very difficult to prognosticate. There,
So
how
go.
do we start initiate this palliative care in discussion itself? How do we try to explain to the patient from the very beginning where we need to stop?
See, that will be it can be made easy if it is done by the parent team. All these chronic diseases will be seeing one doctor for 20 years. Am I right or not?
Right. Absolutely.
Yes. See, in that 20-year period, that 18th year, they have to see, for the simple example, COPD or ILD, the person would have been using 2 inhalers for 15 years. Then 17, 18 years, it would have been 3. Then it will become 4. Then 4 inhalers plus 4 tablets. In spite of all this, the patient will be breathless. That is where they have to pick up. Okay, and then these prognostic, there's another index also called as Walter index. Okay, today you got a couple of index scales. Add on that Walter index also. That also is very clear. It adds on that albumin. Protein is one of the important factor. Any protein less than 3, albumin less than 3 is a poor prognosticator. Okay, so put all that, and as you said, oncology has better, clear evidence, like 80% things are there. Whereas non-oncology, it may not be there. Okay, but that too, it's not said that non-oncology. Non-oncology, you make it a prolonged effect. Okay, in that front, they have to start, and when these figures are all not correlating, then you start telling to them, and then patient themselves will start feeling. And then start the palliative care approach. They're non-pharmacological. A lot you can use non-pharmacological methods. Okay, in so many sessions you've had non-pharmacological and pharmacological. And then as deterioration happens, then you start the palliative thing also. So we are not jumping here into palliative care. One clear thing, please, all of you take, as Dr. Rajagopal mentioned, we have all been acute treating physicians only all the time. Even now, if there is a choice that I could get benefit out of it, I would put 200% to get that patient out of ICU. But where there is no possibility, then you think of this, because it is unfair to torture or make a patient go through all this. If it was you, and then there are many articles in which, for example, there's an article also in which they say, there are some figures say, many of the doctors, if they have done research and found out, if you ask doctors what they want, they don't want intensive care. When you don't want intensive care, why are you doing it or forcing it on your patients? Because that study has come and said that 80 to 90% of them all have said that they did not want intensive care. Okay, so 1 minute, let me share. I just wanted to show one thing alone, which you've all seen and heard many times. Can you all see my screen?
Yes, ma'am.
Yes, ma'am.
Okay. See, this is just this one. All of you have heard about it many, many times. These are the 4 roads to death. Okay. And this, I'm just going to take you through this again because this is one of the important things to be aware of. Okay. Proposed trajectories of dying. This one. First, the first one, that is sudden death, no, is said to happen only in 7 to 10% of the population. And you see, it's an important things what I'm asking you to note alone, keep an eye. Function is on the vertical axis and time on the horizontal axis. See the function of a person who is on that first graph, the functionality is so high, okay? They are performing everything as they are doing, and then sudden death happens. And as I said, it is only 7 to 10%. And Dr. Abdul Kalam is one of the persons normally is said as an example for that. Okay, then go to second one, that is terminal illness. In that also, see, functional performance is still high there also. And this is called as a waterfall effect. This oncology patients all mostly come into this, which forms about 10 to 15%. Okay, or 15 to 20% also can come in this. So the performance is high and sudden deterioration in their performance status mainly because of the disease. Okay, and then come to the third one. This third one is again a big chunk. Okay, again 20% it could be. 20, minimum 20% they say. But see, few factors alone I want you to understand this, and I can explain it once again also if required. See, first, the performance status is not in high as 1 and 2. Why? Because the disease per se causes other multi-organ damage or end organ failure. All these terms all of you would have heard. Okay, so that is why the performance to begin itself is not in high, it is low. Okay, so that is because of the disease. And then every episode or incidence of, like, whether it is an acute on chronic infection or admissions to hospital or other comorbidities, every time, every episode, they do recover. Not that they're not. This all importance of ICU, and they are recovering. But when they come back, you have to extrapolate. For example, take the third episode. They have the episode, come back, and when they come back to normalcy, extrapolate it to the vertical axis, and it is at least 50%. That is, functionality itself to start off was low, and in that, from that performance, it has come down by another 50%. Just the third episode. If someone has 6 episodes in many things, another prognostication factors, how many hospital admissions in the last 6 months? In the last 6 years, 1 or 2. In the last 6 months, 6 or 3 means that is one of the bad prognosticator. Okay. And then the last one is frailty. That 40% also can fall into that. Okay. So this is how is the main important thing in that to understand. The frailty one is a very low, slow progress. Okay. Any elderly, octonanogenarians all will fit into that. Okay, is that clear? Anybody wants me to explain anything? I've just come out of it. Anybody wants me to explain anything on that, or is that clear? Okay, then a few more things what when we were seeing, and even in the presentation which Dr. Bhattacharya did, there was a point about giving midazolam and thing. See, there, one more thing all of you to be aware of, so there's something called as doctrine of double effect. In that, main points to understand is, whenever some medicine is given, for example, morphine is given, it causes sedation, but at times it can cause a little bit of respiratory depression also. But the intent of giving midazolam there was for sedation. So when these type of things, two effects are there, when it happens simultaneously, it is not, the intention was to give sedation. The intention was not to cause respiratory depression. That is what is called as doctrine of double effect. Okay. Another common example, what we say is, when someone has a ruptured ectopic pregnancy, salpingo-oophorectomy is done. So that is done to save the mother, not intentionally to remove the fallopian tube. Okay. So this is something you may all read. What is doctrine of double effect? This is something to be aware of in this context. And subcutaneous infusion. In your wound management session, were you told anything about that? No. Okay. If not, Sangeet, just some information about subcutaneous infusion. If we could share, maybe better. I will talk to you, Sangeet, about it.
Sure, ma'am.
Okay. We will, because see, subcutaneous infusion is one of the mode which can be done. And it's not rocket science. All of you know that. All of you know butterfly? IV butterfly access? With that, you can do subcutaneous infusion. Okay. So it is not something difficult. Only thing, you cannot give large volumes. You cannot use it as an IV infusion. And you use it when the indication is there. When you want to just give a fluid, as we say, no, in last few days, or it is used for giving, subcutaneous infusion is used a lot for giving even painkillers. We use it for giving fentanyl when patients cannot have, and we use it a lot in end-of-life sedation. So subcutaneous infusion is something which can be used, and it has its own pros and cons. And another thing is that at end of life, when the body is entirely shutting down, you don't need IV fluids. You may cause more harm than benefit. Okay, only thing, all these things, it is our responsibility to explain to the family, because the family is one. Patient will not be in a situation to ask you all this. It is a family, so it is a family whom we have to explain things to them about it. So that can be done. And many times respiratory depression and all the difficulties felt at end of life care are more from family and carer point of view. So explaining to them what is happening, what to anticipate, how to manage, that is what is more important. Okay, so just for the subcutaneous infusion, we will try to send some material. And I think if you have the primer has the material in that. Okay. If you have, I remember Sangeet telling that you have all got the soft copy of the primer. So please have a look. Okay. Please have a look. If you don't find, put a message in the WhatsApp. Clearly, I'm telling only if you don't find. Okay, you should be able to find because that is there. So I think those were the things which I wanted to add on. Anything else? Anybody has any query or doubt? Go through these prognostication indicators, what we've said, and look up about Walter index also. So that is something which is used. And advanced directives and things, all what Dr. Rajagopal has mentioned is in Pallium India website. And still advanced directive and all, many places in India, many are not aware. And even if we say they are not willing to take, and these things, no, like even in today's, how many are willing to talk about death? Fortunately, I had parents who were willing to talk, and God blessed us with not going through any of the consequences which happens. Really, it was a blessing to have parents like that and being able to talk about it. So, because everyone, not only the person, family, everyone needs dignity. When we all talk about dignity during our life, dignity at the time of death is also equally important. Okay, then if there are no more queries, I'll just have a check at the chat box. Okay, no more queries in the chat box too. In that case, I'll hand it over to you, Sangeet.
Thank you, ma'am.
I think things have been clear, because if no one is asking me, either everything is very clear or everything not clear. Only two options. Okay, okay, to you, Sangeet. Over to you.
Thank you, ma'am. Thank you for the session and facilitating the session and all. Thank you all for joining. Thank you, Dr. Bhattacharya, for presenting the appropriate case presentation also. Thank you. Let's see in the final session. Thank you. Bye.
Thank you, everyone.
Thank you.